Hi, everybody. We're all here. The participants, the presenters are all here, but we will wait like perhaps a minute or two. Make sure to give the chance to everybody to join us. So if you don't mind, we'll just kind of be waiting.
Super.
Mila, are people still coming in?
Yeah, there's people joining in the waiting room every now and then. I'll keep an eye on it, and we'll let people in as they enter.
All right, so why don't we start if it's okay with everybody? So on behalf of Michael Barkham and Wolfgang Lutz, I would like to welcome you to a webinar on therapeutic ingredients that explain, at least in part, why and how psychotherapy works. We are pleased and honored to have two highly influential researchers in our field, Mary Beth Connolly Gibbons and Bruce Wampold, who will present on the empirical evidence supporting the role that process variables and therapist effects may play in clients' improvement. This webinar is part of a series based on the 7th edition of the Berin and Garfield Handbook of Psychotherapy and Behavior Change, a series that is jointly sponsored by three organizations: the Society for Psychotherapy Research, SPR, the Society for the Exploration of Psychotherapy Integration, SEPI, and the Society for the Advancement of Psychotherapy, the Division 29 of the American Psychological Association. This is the sixth webinar of this series, and based on where many of us live, this is the first of the winter in 2003, following presentations on quantitative and qualitative methods, training and supervisions, the combinations of medications and psychotherapy, as well as research on psychodynamic, humanistic, existential, and systemic approaches. If you missed any of these webinars, as well as one that introduced the handbook, featuring two of its previous editors, Alan Bergen and Mike Lambert, you can have access to their recording on the SPR website, and this webinar will also be recorded. You should also plan to attend future webinars, including one that has already been scheduled for December 6th at 11 o'clock Eastern Time, when Michelle Newman and Evan Foreman will address the current status and future directions of research on the first, second, and third waves of cognitive behavioral therapies. Today's webinar will be lasting up to 75 minutes and involve three segments, two given by each of our presenters respectively, and then a segment of 15 minutes or so for questions and discussions. So without further ado, I'm now inviting Mary Beth to talk about process and outcome research. Mary Beth?
Right. Let me share my screen. Okay. Can everyone see that?
Yes.
Great. Well, nice to be here and to see all of you. I'm Mary Beth Gibbons, and I'm going to present a chapter that I co-authored with Paul Christoph on psychotherapy process and outcome research. And in this chapter, we tried to focus specifically on advances in understanding causal connections. So we all know that there are decades of psychotherapy process outcome research. There are hundreds and hundreds of studies, and these have been well reviewed and summarized in previous versions of the handbook. This body of research we feel is essential for not only understanding the process of psychotherapy, but this is the core to how we're going to learn about treatments, how to adapt them, and how to improve them and integrate them in order to optimize outcomes. One problem with this very broad base of research is that many of the studies are based on simple associations. That's often a result of just the opportunity that we have in terms of sample sizes and design. But it does lead us to the question over and over again of how do we rule out spurious correlations? There have been newer designs and statistical methods used since the last edition of the handbook that improve our ability to make causal inferences. Some of these methodologies include experimental manipulation, but also studies that establish time precedents. So these are studies that are looking at process and mechanism variables that are predictive of subsequent symptom course and increasing our confidence that the relationship is actually causal. There are studies examining within patient associations, which do a good job of ruling out between patient confounds. Of course, there still could be within patient confounds. There are studies that can use sensitivity analyses to evaluate whether results hold up, assuming a certain amount of confounding. And there are modern causal inference statistical models that are starting to be used. These are great for controlling the vast majority of unmeasured confounds. But of course, one of the problems with these approaches is they do require the large sample sizes that are very difficult to get in psychotherapy research. There's instrumental variable approaches and copula-based methods that are, I think, well described in that paper by Falkenstrom. So when we wrote this chapter, we decided that the vast literature had already been well reviewed. And so our goal was to first review some of the methodological concerns that exist with the literature that we have, and then to specifically review just those studies that we felt had made some advances in their methodology to address causal inference. And for this reason, we focused the chapter mostly on studies published since the last edition of the handbook. And again, we do still review studies on both common factors across psychotherapies, but also on processes and mechanisms that are specific to particular therapeutic models. So just as a little background, when we wrote the chapter, some definitions we used. For psychotherapy process, we used the definition described by Orlinsky in 2004. So these are actions, experiences, and relatedness of the patient and therapist in the therapy session. And when we use the term change mechanisms, we're referring to changes that are occurring within the patient across the course of their psychotherapy that are hypothesized to have a relationship to treatment outcome. So let me first do a brief review of some of the methodological concerns. Again, we have hundreds of studies showing associations between process variables and psychotherapy outcome. And despite the number of studies, it's still difficult to draw causal inference. So the first problem is there are many studies that lack control of confounding variables. And so we know that simple associations don't control for confounding variables and therefore are limited in their ability to infer causality. Of course, experimental manipulation is probably, we think, one of the better methodologies for controlling for confounding variables. But there's also, as I mentioned, the modern causal inference statistical approaches that can be used just simply with correlational data, which is the kind of data most of us have access to. And we think something important is, again, establishing temporal precedence. So looking at whether the change in the process is actually driving the change in outcome. We do see many examples of reverse causation. So for our chapter and for the presentation today, we focus on studies that use designs to improve causal inference by controlling in some way for confounding variables. Another methodological concern with our very large research base is not accounting for multi-level effects. So we know that psychotherapy is a dyadic relationship. Both patients and therapists could be contributing to this process. And I was intrigued by Baldwin 2007 pointing out that the process outcome association could be occurring in different directions for patients and therapists. And so collapsing across these can lead to very misleading findings. So understanding the patient and therapist contributions of the process outcome relationship, they're needed. Why we think this is so important is that this is what's going to lead us to clinical recommendations. So associations happening at the therapist level, give us a different clinical recommendation than associations may be happening at the patient level. So for this reason, we highlight studies that explore both the patient and the therapist contributions to the process outcome relation. And finally, one of the methodological concerns we wanted to point out is the lack of specificity of effects. So process outcome associations and mechanism studies are rarely addressing these effects across diverse psychotherapies. Often a process or a mechanism is studied within a particular therapeutic model. And then if there's an association, there's the assumption, there's the inference that it's those specific interventions that are leading to that process outcome relationship. But in order for us to create clinical recommendations based on process outcome findings, we think it's necessary to demonstrate that the relation was due to the specific interventions of that intervention. So for this reason, we highlight any studies that have been published that demonstrate specificity of effects. So let me start with common factors. Because of limitations today, I'm only going to focus on the therapeutic alliance. In the chapter, we do focus on other important common factors like the real relationship, but there have been some advances in process research on the therapeutic alliance. So I'm going to focus on that today. So Flukinger 2018 reviewed 295 studies of the alliance. It's probably one of the most studied constructs in the psychotherapy literature. But what you find in that review is that few of those studies control for confounding variables, with the exception that there are a number of studies that try to rule out reverse causation by controlling for early symptom change. In the 6th edition of the handbook, for those studies that controlled for that early symptom change, we reported that the alliance outcome correlation was on average 0.24. Now, since that publication, there have been 4 additional studies looking at the alliance outcome association that specifically controlled for early symptom change. But those resulted in mixed results. So 2 of those studies are showing that the alliance drives subsequent symptom course, and 2 of those studies are showing that early symptom change is actually driving the alliance. So there's much more we need to know about confounding variables and specifically this early symptom change in understanding how the alliance might be driving outcome. In terms of controlling for confounding variables, there's one additional study by Christoph in 2018 that used an instrumental variables approach. So this study demonstrated that there was a significant association between the alliance at the therapist level and treatment outcome when you control for the broad range of confounding variables. So definitely some improvements in how we, in terms of adding to the literature studies that are attempting to control for confounding variables, but still much more to be done. There's been a big advance in using multi-level modeling to study the alliance outcome relationship. So in the Flukinger review, again, the average association of the alliance and outcome is a correlation of 0.28. In the studies, though, that have been published since the last version of the handbook, there are 8 studies that we found, and They all use multi-level modeling where they parse out the patient and the therapist level effects. But what we find are very mixed results. So there are 5 studies where the alliance at the therapist level is predicting psychotherapy outcome, and only at the therapist level. So this is important because if it's only at the therapist level, that leads us to start thinking about how we can think more about training in the therapeutic alliance. But in contradiction, there are 3 studies that show that only alliance at the patient level is predicting psychotherapy outcome. And this might lead us to different recommendations. If it's not being driven by the therapist, we might start thinking of alternative approaches for certain patients, like medications. And so what this leads to is we feel like there's been a big advance in multi-level modeling of the alliance outcome relationship, but there's going to need to be studies of moderators of the patient and therapist level effects so that we can better understand when the patient is contributing to the alliance outcome relationship and when the therapist is, and so we can develop treatment recommendations and I think training recommendations. One of the biggest advances since the last publication of this chapter is using multi-level modeling to examine within patient effects of the alliance predicting next session outcome. So this is a great methodology that controls for those between patient confounding variables. So Zilchamano published a review in 2017 across 8 studies that used within patient effects of the alliance on the outcome in the next session. And then since that review, there have been 4 subsequent trials. 10 of those 12 studies report a significant within patient effect of the alliance on the next session outcome. So these are studies that are controlling for confounding variables and showing some temporal precedence. So by controlling for these, I think this is really moving the alliance outcome research in the direction of greater confidence that this is a causal relationship. All right, I'm going to move on to some of the things we've learned since the last publication in terms of specific processes and mechanisms described in specific models of psychotherapy. Again, the chapter does a broad review. I'm going to highlight today some of the areas where I think there have been advances. I'm going to start with change mechanisms for cognitive behavioral therapies for anxiety disorders. And one of the areas where there's really been an advance in methodologies to improve our confidence in causal inference is in trauma-related beliefs in the treatment of PTSD. So there are now 5 trials that demonstrate the change in trauma-related beliefs predicts subsequent symptom course in PTSD treatments, especially the exposure-based therapies. There's also 2 studies that show that mediational effect of beliefs, belief change, were specific to prolonged exposure compared to medication interventions. So these results are promising. They're indicating that there's both some specificity of this change to prolonged exposure treatments, and they're showing temporal precedence, giving us greater confidence that it's the change in the beliefs that's driving the symptom course. Of course, we would also recommend that future studies try to demonstrate specificity of these effects relative to other psychotherapeutic approaches. That I think is important if we're going to recommend specific therapeutic interventions for PTSD. Next, I want to review what we've learned about change processes in cognitive therapies for depressive disorders. So these results are particularly mixed when we look at studies using newer methodologies to try to improve causal inference. The results are just mixed on whether use of cognitive therapy techniques are predictive of symptom course. I'll point out a few notable studies that I think are very promising. There are 2 studies that show that cognitive therapy competence is predictive of subsequent depressive symptoms course. So this is important in showing that temporal precedence. There's also 2 studies that demonstrate that the within patient effects for cognitive therapy predicting symptom change by the next session, controlling for potential between patient confounders. So these studies, again, I think provide some confidence that there may be a causal relationship between cognitive therapy competence and treatment outcome. but the mixed nature, the results, when you look at all the studies published, indicate that we're going to need to look at moderators again of these effects. So there's a couple publications showing that symptom severity and gender may moderate the relationship between cognitive therapy competence and outcome. So again, research moving forward is going to have to find ways to control for confounding variables and improve causal inference, but also include important moderators so we understand when these processes are relevant. Next, I'm going to talk about change mechanisms in cognitive therapy for depressive disorders. There are, of course, multiple proposed mechanisms for cognitive therapy, including changes in dysfunctional attitudes, underlying schema change, and acquisition of compensatory skills. And so by this, I mean that helping patients decrease their depressive typic kind of thinking and improve their more adaptive cognitive strategies in the face of depressive typic events. What we see in the literature to date is no consistent evidence that changes in dysfunctional attitudes or underlying schemas are associated with subsequent symptom change across psychotherapy. So that's an area where more research is going to be needed to identify whether those are important change mechanisms. There is starting to be some compelling evidence, though, that the acquisition of compensatory skills may be causally related to outcome. There are now multiple investigations demonstrating that improvements in compensatory skills are associated with symptom change, some of them looking at prediction of subsequent symptom course. And a recent study by Kurtz-Christoph showed that improvement in compensatory skills predicted subsequent symptom change in cognitive therapy, but not in dynamic therapy. So this is an important study. It gives some evidence of specificity of this effect to cognitive therapy, and also improves our confidence by showing that it's driving subsequent symptom change. Now, I will note in this study that there was change in compensatory skills in both the cognitive therapy and the dynamic therapy condition. But it was only within the cognitive therapy condition that that change drove symptom course. So I think there's still a need for more studies to kind of show that this mechanism is specific to cognitive therapy. All right, I'll move on to what we've learned about change mechanisms in behavioral activation for depression. So there's a meta-analysis across 26 studies demonstrating the superiority of behavioral activation to both control psychotherapy conditions, but also medications. So there's a very strong accumulating evidence base. There's multiple studies now that demonstrate an association between activation in the patient, behavioral activation, and symptom improvement. And there's an important study in 2017 by Gibbons that shows that it's early change in the patient's activation and improvements in their reward value of their experiences that's predicting subsequent symptom course. And she found actually that it also mediates the differences between the outcome difference between behavioral activation and treatment as usual. So this is an important study, again, showing that time precedence of the mechanism, but also showing some specificity of that effect to the behavioral activation interventions. So given the strong evidence that's accumulating for behavioral activation, there does need to be more studies confirming this causal relationship between activation and reward and decreases in depression. This might be an important process outcome for psychotherapy moving forward. All right, let me talk about what we found in the literature for change mechanisms on treatments for borderline personality disorder. There is one study that pooled 3 separate studies of dialectical behavior therapy. This study found that patients in DBT use 3 times more DBT skills by the end of treatment than those in treatment as usual. They also found that staying in DBT longer was associated with increased skill use and better overall outcomes. This is an important finding. It does look like there may be some evidence that these acquisition of DBT skills is particularly important in borderline personality disorder. But we did feel that there needs to be more studies on whether this acquisition of DBT skills is in fact specific to DBT interventions compared to other options. Nori in 2013 had an interesting study that I think is worth mentioning, although it's not a mechanism study per se, in the way we're using the term. They did use an instrumental variables approach to control for the range of confounding variables to evaluate the impact of the quantity of number of sessions as well as the competence of the CBT clinician, with an outcome being suicidal acts and inpatient hospitalizations, again, for borderline personality disorder. And when they control for confounding variables using this instrumental variables approach, they found that CBT effects were the greatest for patients who were receiving kind of the right amount of therapy from the highest competent therapists. So again, I think pointing out that this process mechanism work, when you take in the complexity of psychotherapy, is providing the most interesting and usable results. There has been a little bit of research on change mechanisms for treatments of eating disorders. There's a review by Lenarding that shows that reducing dietary restrictions is associated with behavioral outcomes for bulimia nervosa. And so this is a large review, but something to point out is that none of the studies in this review showed temporal precedence. So none of them showed that reducing dietary restriction drove subsequent symptom change. And there's no evidence of specificity of these effects to specific treatments, which is what we're going to need in order to make treatment recommendations. There's also a study by Farrell in 2019 showing that looking at mechanisms of exposure-based cognitive therapies for eating disorders. And they found that decreased eating-related cognitions and anxiety regarding eating predicted symptom severity at discharge. It's a promising study, indicating more studies need to be done, I think, to show that this mechanism is actually predicting subsequent symptom course and to show specificity of effects. I'll take just a few minutes to review some additional studies on change mechanisms for treatments of alcohol and substance use disorders. There are few studies demonstrating causal effects for coping skills acquisition or change in beliefs as mechanisms in CBT for alcohol and substance use disorder. I'll point out two more recent studies. In Roos 2017 showed that coping at the end of treatment mediated subsequent one-year outcomes for CBT compared to two other active psychotherapy groups, motivational enhancement therapy and 12-step facilitation. This was for alcohol use disorders. This is an important study indicating that there may be a causal relationship, but I'll point out that this effect was small and it was only demonstrated with high severity patients. Again, pointing that our ability to understand understand process outcome relationships is going to be driven by focusing on moderators like severity of symptoms. In 2018, there's a study looking at CBT for comorbid anxiety and substance use disorders, showing that greater improvement in anxiety sensitivity for CBT compared to usual care. So some evidence of specificity of this mechanism to CBT. And it also showed that improvement in anxiety sensitivity mediated the treatment effect on subsequent alcohol use outcomes. So this indicates that, improvements in anxiety sensitivity, especially for this comorbid population, might be particularly important for substance use outcomes, and indicates that there is potentially a causal relationship here, but certainly more studies need to be done. Right, now I'd like to review what we've learned about change processes in dynamic psychotherapy. I'm going to start with the use of dynamic interventions. And again, focusing on studies that use some methodologies to try to improve causal inference. Since the last publication of this chapter, there were 4 studies that show that the use of dynamic techniques were related to subsequent symptom course for broadly anxiety and depressive disorders. And there's still one paper by Barber in 1996 demonstrating that competence in dynamic techniques is driving subsequent symptom course. We certainly need more studies with specific diagnostic groups to understand this relationship of use of dynamic techniques and competence of dynamic techniques. And something that we want to point out for research moving forward is that often our studies of adherence competence, just based on practical issues, are limited to estimates of adherence and competence from a single session. And these are not likely to be dependable estimates of adherence and competence. And so it's really going to influence the findings that we get. So in order to really understand whether there's a causal relationship between adherence and competence, we're going to need to move towards more generalizable estimates of this effect. There's also some evidence in the previous literature that quality of interpretations may be associated with outcomes, but this is something that's not been studied more recently. So there are no studies designed to really understand that causal pathway. There have been, we think, some advances in identifying change mechanisms in dynamic psychotherapy, again, paying attention to causal inference. So Jennison in 2018 published a meta-analysis demonstrated a moderate association between improvements in self-understanding and psychotherapy outcome. Included in this review are 3 studies that establish temporal precedence. So these are studies that are showing that improvements in self-understanding are driving subsequent symptom course. There are also 2 studies demonstrating specificity of this process outcome relationship to dynamic therapy compared to other active psychotherapies. So there's more evidence that there's actually a causal relationship between self-understanding and symptom course. There's also been some studies of reflective functioning as a mechanism of dynamic psychotherapy. So Levy in 2006 showed specificity of change in reflective functioning to dynamic psychotherapy. An additional study in 2018 showed that improvement in reflective functioning was associated with a decrease in symptoms for borderline personality disorder. So this seems to be an important mechanism of dynamic psychotherapy, but certainly more studies are needed to show the temporal precedence that reflective functioning is actually driving symptom course. And finally, within dynamic therapy, there are some studies, additional 4 studies we found looking at defenses as a mechanism of dynamic psychotherapy. So 4 studies showing that changes in defensive functioning were associated with symptom course, specifically for those with personality disorders. But we didn't find any studies that unpack that temporal relationship between changes in defensive functioning and symptoms.
For 2 or 3 minutes, Mary Beth?
3 minutes, okay. So let me jump to overall conclusions. So there have been methodological advances in psychotherapy process outcome research. We need to go beyond correlational studies if we're going to have confidence in this causal relationship, because it's difficult to make clinical recommendations on correlations alone. But we do feel like there's been significant progress since the 6th edition. Let me just point out a couple research recommendations that we think are new and have better justification, and a couple clinical recommendations. So for research, we think the standard moving forward should be process outcome studies that are designed to establish temporal precedence and to control for confounding variables. 12 new studies that are looking at within patient effects so that they can rule out patient confounding. And many of these studies use that lagged analysis. This is an important new advance in our process outcome research and probably should be the standard for studies moving forward. These designs we think are important if we're going to derive clinical recommendations. there's been little progress examining the specificity of mechanisms across psychotherapy. This needs to be an important thing moving forward if we're going to derive clinical recommendations. And something we learned too is that the same process may not lead to good outcomes for all patients. What's going to be important in process outcome research is, again, really paying attention to the important moderators of this relationship. Based on some of the research that we reviewed since the 6th edition, there are some important clinical recommendations. We have improved confidence of the alliance outcome relationship, that this is actually a causal relationship. And this indicates that training programs really should have a strong focus on training in the alliance. There's a stronger evidence now that there's a causal relationship on improvements in self-understanding driving symptom course in dynamic therapy. There's stronger evidence that at least the adherence to concrete techniques in cognitive therapy are driving symptom course. And a few final clinical recommendations, again, based on the newer studies that address causal inference. There's strong evidence that compensatory skills is actually driving symptom course in cognitive therapy. So attention to this as one of the primary mechanisms of cognitive therapy is going to be important for training and implementation of cognitive therapy. And finally, one of the other areas where there's really strong evidence is this trauma-related beliefs as driving symptom change in PTSD, indicating that this is going to be an important mechanism moving forward. So I'm going to stop there and thank you very much.
Well, thank you, Mary Beth. This was a very impressive presentations, both the clinical relevance of the finding and the rigor. I think you're proposing very important challenge for researchers. And I think that both science and practice will benefit quite from these recommendations that you're making. It's also, I think, a great way to solidify our understanding about some very important phenomena, such as the alliance, for example. So thank you very much. I'm sure that many people want to ask questions and have comments about this talk, but just to make sure that we have all the time that we need for presentations, why don't we reserve the questions at the end? We're going to have 15 minutes or so, and before we do that, we have Bruce to talk to us. But thanks again, Mary Beth. Really appreciate this.
Thanks, Louis. It's great to kind of, in quotes, see friends in the audience and others as well. So eager to talk about therapists, the person who delivers the treatment. And often this is a discussion that we don't have in what works in therapy. So I'm going to start off by just saying, psychotherapy is a pretty amazing treatment. We meet with a patient typically 15 minutes once a week, and it works as well as medications with greater lasting effects and without side effects. We should just take a second to recognize how effective this treatment is. But how can just sitting with someone talking for 15 minutes possibly work? Well, I want to start by looking at luck versus skill, an interesting book on different activities that involve either luck or skill. In chess, the more skilled chess player typically wins. If you look at the latest world championship, Magnus Carlsen and his opponent tied most of the games. They were draws because they're equally skilled. But of course, roulette and lottery are all luck. National Hockey League's about in the middle, and so forth. So the question for me is, where does psychotherapy lie on this dimension from luck to skill? Is it the outcome based primarily on the skill of the therapist, or is there a lot of luck involved? We know some patients have better prognoses, life events happen during therapy, and so forth. So anyway, Jesse Owen, my co-author, and I summarized the evidence for therapist effects in the handbook. So what are therapist effects? Well, here's 3 therapists. They each have a patient with a very good outcome, one with an average outcome, and one with a poor outcome. In this view, the therapists are equally effective. You know, some patients are motivated, low comorbidity, and they're good candidates for improvement. They're also treating patients with difficult context and difficult presentations. Now, here the therapist effects are really nil because they're all getting a good, average, and poor outcome. But as opposed to that, consider this instance where therapist 1 has relatively good outcomes with all of his or her patients, and therapist 3 relatively poor outcomes. Now we have therapist effects because therapist 1 across a range of patients clearly has better outcomes. In terms of, and as you know, I like statistics and was trained in mathematics. So the definition of a therapist effect is really a intra-class correlation coefficient. How much of the variance in the outcomes is due to therapists compared to the total variance? And you can calculate it either in analysis of variance or multi-level models that estimate those therapist variability. So let's look at the questions that we have. First, do therapist effects exist? And we're going to examine in randomized clinical trials and naturalistic settings. And how large are these therapist effects, and are they important? And if there are therapist effects, the most important question is, what are the characteristics and actions of effective therapists? So let's look at the evidence. In clinical trials, and we should note that in clinical trials, the therapists are selected for their skill, they're given extra training, they receive supervision in many trials, 1 hour supervision for every clinical hour, and they're monitored for their skill and for their adherence. Here, about 3% of the variability in outcomes is due to the therapist. Now, this may not seem to be very much, but I'll make the case it is. In naturalistic settings, where patients have a variety of diagnoses and comorbidity, and therapists constitute a range of therapists as opposed to the clinical trials, about 7% of the variability in outcomes is due to the therapist. So thanks to Michael Barkham and his group in the National Health Service, here's a diagram of therapists ranked from the poorest to the best. So the poorest therapists in red, consistently below average, and the best therapists consistently above average. Now, you can see that there's quite wide confidence intervals for each therapist, because when we estimate the effectiveness of therapists, we're looking across their patients, and of course there's variability within therapists. But as you can see, the green therapists consistently above average, and the red therapists consistently below average. Now, if you compare the effects for therapists in practice, you'll see that in meta-analyses, the size of the effect is larger than many of the common factors, or at least close to what we see for these other common factors. So therapists make a difference. There is a therapist effect. Let's talk about the importance of therapist effects. I think this is important to illustrate. So Jeb Brown and I did a study of data from a managed care company. We looked at the outcomes of the therapist in the first period, and then ranked them from the best to the poorest. And we wanted to look at their outcomes in year 2. Well, the top quartile in year 1 had twice as large effects in year 2. So there's consistently effective therapists. Now, on the downside, there were some therapists in this data set who never helped a patient in any of the time studied. In other words, all their patients deteriorated over the course of therapy. So therapists make a difference. In the data I showed you before, 19 of those 119 therapists were below average. If you reassigned their nearly 2,000 patients to the other 100 therapists, not to the best therapist, but just randomly assigned them to the other 100 therapists, an additional 265 patients would have recovered. So therapist effects are important. They make a difference. And it turns out, again, thank you, Michael, for your group and this data. The longer therapy goes on, the greater the therapist effects, or the more apparent they are. As you can see, the above average therapists continually increasing over time the probability of recovery. The poorer therapists, by the 15th session, the probability of recovery for any of their patients is 0. So again, an illustration of how important therapist effects are. For time, I'm going to skip this one. You see psychiatrist effects even giving medication. So the best psychiatrists got better outcomes with placebo than the poor psychiatrists got giving antidepressants. So recommendation, I guess, go to a good psychiatrist and get a placebo. But this leads us to the important question. If some therapists are more effective than others, what are the characteristics and actions of effective therapists? Well, in 2004, Larry Butler in the Handbook reviewed the literature on therapist effects. And he said, we don't know and we don't care, okay? Because in 2004, there really weren't any characteristics or actions of therapists that predicted outcomes. And we don't care because, and this is still the case, we have tens of thousands of randomized clinical trials of psychotherapies, comparing different psychotherapies. And we have about 18 or 19 studies of therapist effects in those clinical trials. So our field cares a lot about which treatment's most effective, and we pay much less attention to this important variable, the therapist giving the treatment. So a little audience participation. I'm going to show you some therapists, and I want you to identify who you think is the most effective therapist. Okay, ready? Okay, well, sorry, my timing's a little off. I'll get to this. So want to identify the most effective therapist? You would observe therapy. What would you observe? What characteristics of the therapy would you attend to? But what about outcomes? Observing therapy, we don't know what the outcomes are. So now, can you identify the most effective therapist? Ready? And this is a typical American, or at least a North American therapist. Ready? Oh, they're baseball players. What do you notice about these baseball players if you observe them? They do very different. You will look at Ichiro Suzuki Whoop. I can't, I don't have my marking tool on, but look at Ichiro Suzuki, played for my hometown of Seattle, legs together. He's the CBT therapist, but to his left is the psychodynamic therapist, and up above is the emotion focused therapist. They're all doing something very different. And by the way, these are all stars. You know, they make $15-20 million a year. How often do they get a hit? About 1 time out of 3, which coincidentally is the NNT for psychotherapy. We help about 1 patient out of 3. Now, we don't make 12 million, but it's an interesting comparison. So in the time remaining, what does not make a difference in therapist outcomes? The theoretical approach used in treatment. We have lots of data indicating there's at best small and non-consistent differences among treatments. Older therapists don't get better outcomes. Personality, Jamie Delgadillo gave the Big 5 inventory, no consistent results linking personality characteristics, at least the Big 5, and outcomes. Ask therapists about their social skills with the standard social psychology validated social skills test, no connection to outcomes. In the United States, professional degree, psychologists, psychiatrists doing therapy, licensed professional counselors and clinical social workers, identical outcomes. Here's an interesting one. Interviews of therapists by experts. When we hire therapists, we always say, let me talk to them. I'll be able to detect who's the best therapist. Absolutely no predictive ability. What about experience? Well, of course, as we see more patients, we get better. But it turns out that's not the case. Over the course of their careers, therapists actually get slightly poorer outcomes. That's a little disturbing, isn't it? Because we all believe that we want to go to an experienced therapist who's seen many types of patients. So, what are the therapist skills? Well, if we can't go to a baseball game and observe who's going to be the best hitter, you know, I went to a Seattle Mariners game, Ichiro Suzuki, best hitter in baseball, didn't get a hit. So, observation. So, Tim Anderson said, I want therapists who I know their outcomes to see exactly the same patient. Well, that's not possible, right? So he did the next best thing. He showed them a video, actually 8 different videos of different styles of responses and patients, and had the therapist record their response. What would you say to this patient after they made this comment? And then coded those responses and then correlated the facilitative interpersonal skills score with outcomes. And this is the first study that was able to predict outcomes of therapy, of therapists, with a test outside of therapy. So, facilitative interpersonal skills, verbal fluency, persuasiveness, emotional perception, affective modulation and expressiveness, warmth and acceptance, focus on the other. Now, what we need to understand is these are not social skills that people express, let's say, at a cocktail party where there's some charismatic storyteller. These are interpersonal skills showed in interpersonally challenging situations where there's intense emotion or withdrawal in the situation. So I classify these as competence and warmth for a reason, and I'll show you what that is. So Ingvild Finsrud just defended her PhD in Norway, did a factor analysis and of all the common factors, and found out that it's really the warmth of the therapist. Does this therapist care for me? Are they working hard on my behalf? And confidence in the treatment. Is the treatment I'm receiving have a reasonable chance of success? Belief in that treatment. So, a few more characteristics of effective therapists. Some strong evidence, well, I would say strong evidence by disaggregation at the therapist level. Mary Beth talked about the alliance, well established now that the alliance is related to outcome at the therapist level. In other words, those therapists who can form an alliance across a range of different patients also generally have better outcomes. Rogerian conditions. So those therapists who are warm, genuine, caring have better outcomes. Weaker evidence for other characteristics. Helena Nissen-Lee at the University of Oslo looked at professional self-doubt. So those therapists who say, you know, I'm reasonably good at what I do, but I could be better, have better outcomes. And if you look at a number of other studies, there's different results that I think are all related to this idea of therapists who have professional humility, are reflective of what they're doing. They're optimistic that their patients will achieve good outcomes, have better outcomes. There are some studies of the relative effects within therapists, okay? So are therapists more effective with some types of patients than others? And here there's some evidence that there's some therapists who have relatively better outcomes with culturally different patients. And the same is true with gender. It's a little unclear whether different types of patients. Are there some therapists who, for instance, are particularly effective with PTSD or with personality disorders, and others with depression, for instance? Not quite clear difference depending on the study. So in the last few minutes, we've established that the skill of a therapist is important. Can therapists improve? So I like New York Times article about Rafael Nadal. Might not be your favorite tennis player, but what's interesting about Nadal is that on his day off at Wimbledon, he practiced with the same intensity that he plays. And there, circled in red, is his coach, helping him refine his technique. So when he lost the Australian Open 2 years ago, another story, my tennis career, I lost. And what does he conclude? I have to go home and practice to get better. Practice of those skills is really important. You know, in many fields like chess and music, experts gradually improve. This is one of the characteristics that Anders Ericsson identified of experts, this gradual improvement. They asked Pablo Casals why at 80 years old he kept practicing if he's the best cello player in the world. And he said quite humbly, I think I'm making progress. So what are the components of deliberate practice? An objective. Which skill do you want to practice? You have a coach that's going to guide you in that practice. Repetitive practice with feedback, just like Rafael Nadal does. So can deliberate practice work? Well, at the Calgary Counseling Center, where deliberate practice is part of the way the center operates, the therapists are actually improving over time, as opposed to the experience level we saw before. So at an agency or a system level, deliberate practice can work. So conflict of interest, but I've been involved in developing an electronic platform kind of based on Tim Anderson's idea about responding to vignettes of difficult patients. And then the difference here is to provide feedback to the therapist about particular skills. So thank you. Remember, therapists make a difference.
Thank you, Bruce. Well, another fantastic talk. The content, there was some convergence with regard to the content, particularly with regard to the alliance, but there was also convergence in terms of the clinical relevance of the findings, as well as the rigor and the complexity. And these talks are really a great example of how unfortunate that we still have a major schism between research and practice. There is so much that research can actually present as way of to stimulate thinking and to be more discriminate, to be more precise about what we think, whether it is about the therapist effect and who are involved with whose clients, as well as what Mary Beth was talking in terms of the specificity of the mechanism of change and the importance of looking at moderators. So congratulations, both of you, for being putting together a talk that in additions of the complexity and the advanced statistical analyses present, it was done really for the sake of improving our understanding of therapy and suggesting great ways to improve it. Let me just open this up for discussions among all of us here. Any of the talk, any questions related to Mary Beth and or Bruce presentation?
Well, to get things going, I have a question for Mary Beth, or maybe it's an observation. You know, you really made a very strong case for this idea of temporal precedence within patients. If the alliance changes in 1 week, are the symptoms reduced in the following time period? As about the best we can do for causal analysis. The observation is this. So I've been involved in a couple of papers that have used latent curve analysis with structured residuals. Patrick Curran is a co-author in some of these papers, so we know they're well done. Yet when we submit them, we get back this comment, it's only an association. Please do not say anything related to causality. So you have to change all the language to associated with. Isn't this about as close to causal relationship as we can get? And how can we really convince reviewers and editors that this is some attribution of at least time precedence and identification of mechanisms of change?
Within latent class analysis? Or broadly speaking across all the methodologies that each give a bit of confidence? I
would say across, but we're really doing, as a field, we're really getting down to this time precedence for a given patient. Yeah, and that's pretty cool.
Absolutely. We've had some success. I think, you know, especially if we're spelling out what we're talking about, of having discussions like in the paper on compensatory skills, of publishing the discussion saying this is evidence that it's the compensatory skill acquisition driving symptom course. So we have had some success, but, you know, maybe educating reviewers of, I think What's interesting is none of the approaches I talked about in and of themselves prove causality, right? Nothing's the perfect experiment. Nothing completely controls for confounding variables, but, indicating for each of these methodologies that they improve confidence that there's a causal relationship over and above a simple correlation, I think is at least the best we can do.
And I think these types of analysis really make the clinical applications much more directly than what we've done prior to that.
Yeah,
So-
absolutely. It's such a broad literature that there's so many processes that have been studied, but for some of them, they might not be predictive of subsequent symptom course. They've never been studied in that way. And so we can't really recommend for therapists to focus on processes that may actually just be a result of early symptom change. So I think it's this kind of research that's going to allow us to actually focus our training techniques for therapists. And these are the processes that we know are going to drive that subsequent course.
Thank you, Mary Beth. Wolfgang, you have your and
Yes.
but you're also you're good. You were on
Can
mute.
you hear me? Yeah.
Yep.
Sorry, I was teaching today and came a little bit late, though I had problems with my micro. I also want to say these are really excellent talks, and I'm really happy we had those two together, though we have the techniques, the competence, and then the therapist effects on the other side. So it's really excellent. Thank you very much. It's another great example for how wonderful these webinars are. And I would agree actually that with the within patient effects and analysis that really brings us forward in looking to mechanisms of change. I mean, that's really a way forward. I to be honest, in some way, I'm a little bit also hesitant to talk about causality, because I like to say we make progress and we have the mechanisms and the time change, but the word causality, it goes so deep. It's also a philosophical concept in a way, and used in the theory of science and in physics and philosophy. So I feel a little bit reluctant to use it in our context. So it is definitely an advantage in studying mechanisms, but the word causality is maybe too much in a way, given that we usually don't know the moderators around and the whole causal net connected to it. But I have also a question to you both. So besides that little commentary, my question would be actually, in terms of the competence and adherence, we have some ambivalent findings, and Mary Beth really nicely summarized it. But on the other side, Bruce, you said, well, I'm evaluating the competence of therapists then also in the deliberate practice video clips. So how do we? There are actually two questions. So first, how would we do this if we are not really sure on our measures? And the other thing is, can we improve our measures in the future? Do you have any ideas how we might improve the measures? So, I mean, I always have that feeling we are very good or getting better and better on the statistical side, on the analytic side with that new patient within variance analysis, but we do not much improve on the measurement side. And I just wanted to hear your opinions on this.
Well, Wolfgang, I mean, it is rather disturbing the number of studies that the competence assessed by experts in a particular treatment does not predict outcome. I mean, what does that say? As supervisors, we're not very good at recognizing the competence of the person we're working with. That's disturbing. Part of the problem, and James Boswell did a great study on this, that the apparent competence is largely determined by the difficulty of the patient we're working with. A really challenging, interpersonally aggressive patient will make therapists appear less competent. So one of the brilliant things I think of Tim Anderson's work is, here's a standard stimulus. So if you break it down, and let's talk about I don't even want to use the word competence, but the skill with which we responded to this particular instance and give feedback on a particular skill, empathy, affective recognition, affective modulation, and give feedback at that level, we're going to be much more successful than if we have kind of ratings of global competence of this particular therapist. And it's really not the therapist, as Mary Beth mentioned. It's often one session of therapy. And then we got all the confounds of the patient we're working with.
Yeah, I would agree. I would agree, Bruce. I mean, for me, again, it highlights the need to include moderators in this analysis. And, you know, the literature that I reviewed on cognitive therapy, CT competence, is a great example. You say we've measured it and it doesn't predict. Well, I think it doesn't predict because we haven't measured it. So, you know, we're measuring it with brief measures in one session. And we all know that it doesn't matter how good my cognitive techniques are, one session can go in a lot of different directions. And there's literature on this of how many sessions we need to estimate a generalizable effect. And I think it's up there with like 6+ sessions. And, you know, most of us can't do that. We've never had enough funding to be able to do that in a really legitimate way. But that's what would be needed to really know whether competence is predictive of symptom course. So I would say we haven't answered the question yet.
Yeah, I agree, Mary Beth. But one of the problems with what do we do with that data? If we say therapist X is more competent than therapist Y, what feedback do we give to the therapist about improvement?
Yeah, that's a great question. I'm not sure I have the answer for that. You know, it opens up a whole range of you know, whatever is missing. So, you know, do they need additional training? Are all therapists capable of having the same skill level? It really opens up a million questions there. So I do want to jump back to something Wolfgang said. So I agree with you. Like when we wrote that chapter, you know, using the term causality, we had a lot of talks about that. And I think in the chapter, and I tried to today, continue to use the language of like, something improves our confidence that there may be a causal relation, because I think some of these methodologies do actually improve our confidence. Are they definitive in causality? No. But I want to use the term causality because I think we have to move the field forward. I think, you know, when I came into the field, there were already a lot of process outcome studies. And the assumption was because there were so many studies that replicated a simple association, therefore it must be true. And there must be a causal relation. So I do think it's something we have to talk about and talk about, as Bruce said, like in our discussions of whether study designs are actually contributing to our understanding of causality.
Great thoughts here. There is a comment in the chat by Todd. Let me read it. Maybe I heard wrong, but it sounded like deliberate practice involves focusing on a specific approach. If so, how is that different from learning a specific therapeutic technique which show no effect? I guess that's for you there, Bruce.
Well, I think deliberate practice can focus either on the skills that I showed, Tim Anderson's facilitative interpersonal skills, for instance. It can also focus on particular aspects that really, I think are important, are how you explain the treatment to the patient. That's kind of Tim Anderson's persuasion. How to terminate a session, for instance. But you could also deliberately practice skills for particular treatments. So Socratic questioning, that's a technique in cognitive therapy. Well, that takes practice to do it better and better in different contexts. So it isn't just with one type of patient, it's across different types of patients with feedback. But it's more specific than this idea about competence in general.
Yeah, I would build on that because I think deliberate practice is extremely important. And, you know, something we learned early in our process outcome research here was, it's anecdotal, but it's always kind of informed how I think about training, which is we had a very young therapist that we were using as judges in a study where their job was to read excerpts of stories patients told in psychotherapy and to extract the interpersonal themes from those stories. And this was a large study. They had to do it for literally like hundreds and hundreds of these extracted stories. So they got very good at it. And then in subsequent years, they were, therapists in some of our studies. And when they went into training, they were already very good at extracting these themes like this. They didn't need any time to process when they heard a story. And so it's that kind of deliberate practice of the steps it takes to like create an interpretation that I think is important.
Great point there, Mary Beth. There was a symposium at the recent NASPR that was emphasizing coding process as a way to learn about therapy. So your comments very much in line with this. It's almost time, but it's 1:15. But Jan, you have a chance for a question there.
Great, thank you. I hope I can explain myself correctly here, but I started wondering, Bruce, when you showed the graph that showed performance by number of sessions, that I think it was for the first 2 sessions, maybe, the therapists that were neither really good or really bad had the best effect. So I'm starting to wonder if there's a relationship between number of sessions and the therapist effect, and if perhaps some therapists are more effective for fewer number of sessions, and maybe centers that are not able to give the full 12 or 24 session back that other institutions can.
Yeah, well, of course, it's complicated, right? As Mary Beth said, there's always a moderating effect. In my reading of the data, both other studies and the data that I've looked at, the good therapists distinguish themselves quite quickly early in therapy. And there's also the more severe the patient, the bigger the therapist effects. So it's not the matching hypothesis that with some kinds of patients, some therapists are better. There are some studies that show this effect, but it's relatively small compared to the differences between therapists. The gains at the beginning of therapists usually are motivated patients. They need some encouragement. They're ready to go. They listen to what you have to say and they implement it in their lives. By the 3rd or 4th session, they show quite significant gains. Well, there's some therapist effects, but they're relatively small. It's the difficult patients, longer term therapy, where it seems like the therapist effects are large.
Which brings us to an hypothesis that Strupp actually had in mind and tried to measure with the Vanderbilt 2 study, which both of you are, of course, very well aware of. Well, both of you, thank you so much for your expertise and such an inspiring, really an inspiring presentation from both of you. Thank you. Thanks, everybody. And we will see you in December. Thank you.
Thanks, everyone.
Thank you.
Bye-bye.
Thanks, Louis.
Good to see you all.
Wonderful. Well done. Thank you both.
Well done. Yeah.
Cheers.
Cheers.